Well, my name is Jack Fisher, and I am retired from plastic surgery. I was an academic plastic surgeon at the University of California, San Diego for many years, and I've been retired almost as many years as I was full-time there. Oh, I knew I wanted to be a surgeon when I was a third-year medical student, but I didn't have much exposure to plastic surgery in my medical school. I was fortunate enough to be commissioned by the Public Health Service and assigned to the National Cancer Institute, where I functioned much as a surgical resident would. And we were doing a lot of major cancer surgery. Surgery for cancer back in the 60s was very radical. It left deformities. We had consultants coming in occasionally to tell us something about the possibility of reconstructing the deformities that resulted from cancer, and I really took to that. Now, in order to get through general surgery, you spend a lot of time on trauma. You have to make a lot of fast decisions. The race and the pace is a trying one, whereas plastic and reconstructive surgery is a specialty where you are dealing with physical deformity and you're working at a more modulated pace. There's time to plan. There's time to get things done over a period of time. When you're in general surgery, consultations tend to be succinct. Um, you're often dealing with life and death issues. You're not dealing primarily with elective surgery, elective problems. So when I came to work with Dr. Edgerton, you spend the first 6 months taking care of his referral practice, and you're subsidiary to him. And what I noticed was that the clinics went on and on and on. And some of the initial consultations took an hour. And I found that to be a drag at first, but then it dawned on me how important they were and how a bond is being established between the surgeon and the patient. And I came to love those clinics. And when I became a teacher years later, I tried to duplicate that experience. Obviously, you have to be a regular attender and participant in its activities. You have to always do a little bit of committee work. One of my goals was to help to nurture a liaison between the academic training programs and and the society, which is predominantly people in independent private practice. So we had a liaison committee between the training programs and the society that was very effective. I hope it still functions. I don't know. And then the very first full-time academic surgeon to become president was Lars Visnes at Stanford. And then a couple, 2, 3 years later, somebody else I forget. And then eventually they asked me if I would do it. And I agreed. I remember a medical student who informed me that he had decided already that he was going to be an ophthalmologist, so that all he needed to know was about the eye. And I said, oh, well, then how are you going to deal with people who come to you with eye problems as secondary to major systemic medical disorders? And of course, he hadn't thought about that. Remember, I said earlier, plastic surgeons have to remember that they're doctors first. They have to screen their patients. They have to make sure that they're not taking somebody who's unstable into an operating room. So I would say uh, I'm excited that you've spotted our specialty, that you are interested, but stay broad. I'm afraid I'm repeating myself, but listen to your patients. Listen to your patients, and stay broad. Be fascinated by all aspects of medicine and medical care. And also, I guess we ought to say you ought to take care of your own health. doctors are not famous for taking care of their own health. And I was guilty of that. I had hypertension in my family, so I discovered as a medical student that my blood pressure was higher than it ought to be. And but I didn't really take good care of myself until after I had my heart attack, and I'm 25 years post bypass surgery. So those 25 years are a blessing because I learned to take care of myself. So how about that for some final advice to people in the learning process, and that is take care of your own health too.